Hey, Rob Fitzgerald again. Thanks for tuning in. We're going to talk about laboratory diagnosis of hemostasis parameters. So we're talking about PT, APTT, activated partial thromboplastin time. We're going to talk about some of the drugs and which tests are best for which drugs. So a PT is a very commonly monitored lab test. It's really the time to convert from prothrombin to thrombin. So it makes sense. It's called a prothrombin time. It's typically somewhere around 10 seconds. And really it's evaluating the factor 7. So factor 7 is activated when you have tissue injury, and tissue factor comes out and it cleaves factor 7, which acts through 5A, 10A to form a clot. So basically the way it's done is in the laboratory we add tissue factor to a plasma sample and we time to figure out how long it takes it to clot. So that's part of the coagulation cascade. Tissue factor 7A activates 10A, 5A, which activates prothrombin to thrombin, which forms a clot. It's commonly changed into, and so we oftentimes will report both a PT and an INR together. And the reason for that is that the reagents differ. Different lots of reagents have slightly different coagulation properties. And so we use this International Standardization Index, this ISI, to normalize a PT so that it can be comparable in different laboratories. So INRs are comparable in different laboratories. PTs are not always. So a PT and an INR oftentimes go together because one is used to determine the other one, and the INR is comparable between labs. It's the best test for Coumadin therapy, and patients on Coumadin typically have an INR somewhere around 2 to 3. A normal INR is 1, so somewhere around 2 to 3 for basic, quote, blood thinning needs. If they're higher risk for forming clots, then you can up-titrate that to maybe 2.5 or 3. And that's typically what is done, is that it's titrated based on monitoring an INR. So sort of an empirical, start out at one dose, typically starting out with heparin for reasons that we'll talk about, and then switching to a more long-acting anticoagulant such as Coumadin or warfarin. Partial thromboplastin time, a PTT, takes a little bit more than twice as long, so 2 or 3 times as long. So normal is about 28 seconds, and it's time for a clot to form. And basically, it's activated in a different way. So instead of coming down the factor 7 pathway, we're going through the factor 12 pathway. So we basically expose plasma to a negative charge surface that activates 12, which goes through the 11, 8, 9 to activate 10. So 10A again activating prothrombin to thrombin, forming a clot. This test is best for monitoring heparin. So patients that are on heparin therapy get a PTT. Patients on Coumadin get a PT and an INR. Heparin is mainly acting through 2A, and as you remember, 2A feeds back to amplify 12A, and so that's why this test is better for monitoring heparin. It's also hemophilia A and B, or when you have a lack of factors 8 and 9, and since they're amplification that come through the factor 12 pathway, this is going to be the best test to pick up hemophilia. So what happens if you have an abnormal PT or a PTT? How do you figure out which cofactor is missing? In many chemistry tests, we would simply analyze for all of the things that could be possibly missing. We don't do that here. Basically, what we do is that we mix a patient sample with a commercially available plasma that is deficient in a single coagulation factor. And so what happens is if you mix the patient plasma with the deficient one and you don't get coagulation, you know that both of them are missing that coagulation factor. So if your commercially available is missing 8 and you mix it with your patient and you don't get coagulation, neither one of them have 8. Whereas if your commercial one has a deficiency of 8 and your patient has a deficiency of 9, when you mix them, the patient's 8 will be sufficient to form a coagulation. So basically you're mixing the patients with the deficient to figure out which one is there, to figure out which one is the missing cofactor. So quickly about some of the drugs that are commonly monitored in the laboratory. Heparin is analogous to heparin. Heparin is endogenously formed. Heparin is exogenously administered. It requires antithrombin to work. And so if patients are antithrombin deficient, heparin's not going to work. It's primarily acting by inhibiting thrombin, which is factor 2, which also feeds back into amplifying 12 and that pathway, which is going to work. 12 is going to activate 11, which eventually activates 10. So there's a variety of different forms of heparin. There's short-acting, there's low molecular weight, and basically, depending on what you're trying to do, you use a different form of heparin. Patients that are on Coumadin, Coumadin can actually cause coagulation early on because of its effect on the protein S and protein C. And so they will put patients on heparin to get them anticoagulated, and then they will transition them off to Coumadin, which is a longer-acting anticoagulant. So Coumadin or warfarin. Warfarin was the initial one. There's a variety of warfarins at this point. And basically they work by inhibiting the carboxylation of some of the cofactors, some of the coagulation factors. And so that's a really important step because that carboxylation puts a negative functionality onto the clotting factor. And if it's negatively charged, it can then bind calcium, which is essential to the coagulation. So without that carboxylation, it can't bind calcium and you don't get coagulation. And so which factors are affected? The sort of the chime that I remember is 2 plus 7 equals 9, and 1 more is 10. So there's 4 coagulation factors that warfarin has an effect on: 2, 7, 9, and 10. It doesn't have any effect on already synthesized coagulation factors. So you've got circulating coagulation factors that are going to be effective until they are used up. And so that's why we typically will start someone on heparin and then we will transition them to warfarin. So they typically start with a low molecular weight heparin. As I mentioned, warfarin inhibits the synthesis of C and S, and C and S act to limit spread of coagulation. So if you block their synthesis, you can actually get coagulation. Again, and that's why we use heparin as a bridge to get them to a stable anticoagulation with warfarin, and we're monitoring those patients to, with an INR to monitor their warfarin efficacy. Newer drugs are somewhat replacing the use of warfarin. These direct inhibitors, some of them directly act on factor 10. And generally, the data looks like they've been well established. They're safe. They have lower risk of stroke, embolism, all-cause mortality. Maybe a little bit higher risk of GI bleeds, and that's somewhat debatable. One of the other benefits is that they typically don't require the close monitoring. Warfarin has lots of different drug-drug interactions, and it's actually fairly difficult to keep someone stable on warfarin, especially with a complicated medical history. There's also a direct thrombin inhibitor. So again, and that's also doesn't require monitoring like a warfarin does. Thrombolytic drugs, so if you have hypercoagulation, for example, if you've clotted and thrown a clot into an artery in your heart, that's obviously not good. Same thing with a stroke. Thrombolytics are actually breaking up that clot and allowing blood flow to resume. So TPA is one example. Streptokinase is another example. And essentially they're activating plasmin, so changing plasminogen into plasmin, which is going to digest the clot. Antiplatelet drugs. Aspirin is the most common one. Has a fairly good recommendation for its antiplatelet effects. And it works by, aspirin is acetyl salicylic acid, so that acetyl group actually binds to serine residues on cyclooxygenase, which is responsible for forming thromboxane A2, which is part of the activated platelet and the platelet aggregation. So it's both a vasoconstrictor as well as activating platelets. Clopidogrel is Plavix. It works by blocking the purine receptors. There's antibodies. So this is the Fab fragment against the 2B3A. 2B3A, if you'll remember, is expressed on activated platelets. It binds to fibrinogen and causes platelet aggregation. And so by blocking that, you prevent that. And the last slide, just talking a little bit more about platelets. They oftentimes go up in inflammation, and cancers are typically inflammatory, so if you have a disseminated cancer, you have an increase in your platelets. Platelets are decrease in idiopathic or immune thrombocytopenic purpura, and basically that is where an antibody forms against the platelet, causing the platelet to be lysed and metabolized. Sometimes that's drug-induced, so drug sticks to the platelet, and your immune system thinks it's foreign and develops an antibody response against it. And so it would make sense that your platelets go down. Thrombotic thrombocytopenic purpura, or TTP, is where your platelets are actually hypercoagulable and they're being destroyed in the bloodstream. And that can also be drug-induced. So drugs can induce that activation of platelets and lysis of platelets. They're also low in bone marrow failure. That sort of makes sense. That's where they're synthesized. So if you have bone marrow failure, you're not forming platelets as well as a variety of other cells. They're also low in DIC, disseminated intravascular coagulation. So that can be a life-threatening situation where your platelets are being consumed because of the coagulopathy. One of the tests that we use here is D-dimer. It is the end product of breaking down fibrin, and so that's factor 12 activates plasminogen, which breaks down the fibrin clot into D-dimer, which can be measured in circulation. So that's a quick overview of some of the important labs in the diagnosis and monitoring of hemostasis. Thanks for tuning in.